Welcome back everybody, David here again with Med School Bootcamp. So in this next video, we are now going to talk about something called renal cell carcinoma. So renal cell carcinoma, or RCC for short, is a carcinoma or a cancer of the kidney. Specifically, it is the most common renal malignancy in adults, which makes it high yield for test-taking purposes. Now, if we look at our pathophysiology here, we see that the most common one that they ask about is going to be clear cell RCC, or clear cell renal cell carcinoma, and it originates in the epithelial cells of the PCT. Remember, the proximal convoluted tubule is the first portion of the nephron after our filtrate goes through the Bowman's capsule. It goes through the glomerulus. So if we look at our anatomy, just as a reminder, our proximal convoluted tubule is going to be this portion right here, right? This then goes into the loop of Henle, the distal convoluted tubule, and ultimately the collecting duct. Now, most cases of RCC are actually sporadic. So they're a sporadic mutation. However, some of them are inherited mutations. And the key here, I want you to differentiate the distinguishing features between these two. So we have a sporadic mutation. It's more likely to be a single tumor. It's more likely to affect one kidney or the other kidney. And it's also more likely to be seen in an older smoker. So when we talk about the presentation. However, a genetic or an inherited condition that leads to RCC is more likely to involve both kidneys and have multiple tumors. And because this is a genetic inheritance, it should make sense that this would present in a younger patient. Typically, we think about inherited things showing up earlier in life and maybe more sporadic things occurring later on in life, just as kind of a general principle. That's not always the case, but as a general rule, it works out pretty well. Now, when we talk about the etiology here, there are some classic associations that we want you to know for testing. The first of which is that there's an increased risk in smokers. So people who smoke tobacco have a higher risk of developing RCC. Oftentimes in a question stem, they will mention this in the patient's history. They might say, a patient presents and, they have a 20-pack year smoking history. This is supposed to be an additional clue for you that they are at a higher risk of developing carcinomas, specifically renal cell carcinoma, if they're dealing with a kidney pathology. Now, some other important risk factors include obesity, hypertension, and occupational exposure. This can include things like asbestos, which we know can also cause pathology with the lungs as well. And I think many students kind of make that connection right away. But you can really stand out and be a superstar if you realize that, hey, yes, asbestos can affect the lungs, but it can also increase somebody's risk to developing kidney tumors as well. And finally, the last one I'm going to point out here is genetic mutations. And the genetic mutation I want you to be familiar with is this one called von Hippel-Lindau, or VHL for short. The clear cell form of renal cell carcinoma is typically associated with this genetic mutation. This mutation is seen as a deletion on chromosome 3, which for the purposes of step 1 is actually a high yield thing to know. It's a high yield thing to remember. And that's why I put the high yield button there. Now, how do I remember that without taking up too much brain space? Well, I remember that chromosome 3 is associated with RCC and the PCT. And so the 3 letters in RCC and PCT help me remember that this is dealing with chromosome 3. Now, step 1 is very big on chromosomes and knowing which number is affected. It's also very big on inheritance patterns. So knowing that this is typically an autosomal dominant condition is worth remembering as well. And recall, an autosomal dominant mutation is typically one we expect to see in each generation, right? Also, given the fact that it's inherited, what age range we might expect to see these types of patients? What we talked about earlier, inherited mutations are typically going to show in a younger patient and often as a bilateral tumor or with multiple tumors. And so as you're reading these question stems, start to develop in your head, are we dealing with a 7-year-old patient or are we dealing with a 70-year-old patient? And this is going to give you another clue in terms of, are we dealing with sporadic mutations or something that's more likely to be an inherited mutation? And also, just for completeness sake, I wanted to point out this is less commonly associated with another autosomal dominant condition called tuberous sclerosis. And recall, tuberous sclerosis is a genetic mutation in either the TSC1 or TSC2 genes that can have a patient that presents with a variety of characteristics such as seizures, intellectual disability. There's oftentimes skin findings, a classic one being ash leaf spots. But it's important to keep in mind these patients are also at an increased risk of developing renal cancer, specifically a renal cell carcinoma. Now, when we look at the presentation here, the classic triad of findings includes flank pain, a palpable mass, right, because there's a tumor in the kidney, we should be able to feel it, and hematuria in the urine. Now, important to keep in mind here, while this is considered the classic triad, only about 10 to 15% of patients actually present with this classic triad. It's more likely that they'll have 1 or maybe 2 of these findings or have a more atypical presentation. And so this is not exclusive. We do not need all 3 of these things to diagnose a patient with RCC, but it's a good idea to keep in mind what are some of the common presenting symptoms for these patients. Next, we're going to talk about age range here, and we said this typically occurs sporadically in older adults. So it's typically a 50 to 70-year-old male who might be presenting with signs of a fever, potential weight loss because they have a carcinoma, or they could potentially be asymptomatic as well. And this is important because RCC is sometimes called the silent cancer because it can often go unnoticed and that a patient is not developing or showing symptoms. Now, really important to keep in mind that RCC is known to develop various paraneoplastic syndromes. A paraneoplastic syndrome is a set of clinical features or substances that are in the body that are in result to a tumor being present. So that is to say we have hormones released, we have various substances that come from the tumor itself and that display themselves as a variety of different presentations for the patient. And a memory aid that we use for this is to remember PAIR for paraneoplastic. So it's P-E-A-R, PAIR, to remember that these patients can develop high levels of PTHRP, EPO, ACTH, and renin. Now, just as a quick summary, do we remember what these molecules actually do in the body? Well, PTHRP is parathyroid hormone-related peptide, which has a similar effect on the body of increasing calcium levels. Significantly elevated levels can actually lead to a condition called hypercalcemia of malignancy, which is elevated calcium due to a malignancy. EPO or EPO is a hormone that is typically released by the kidney, but excessive amounts that are produced in a paraneoplastic syndrome can actually lead to polycythemia, which is an increased erythrocyte count. And if these levels get too high, this can actually predispose a patient to thrombosis due to a high viscosity of the blood itself. Now, ACTH is a hormone that is secreted by the pituitary that can lead to an excessive secretion of glucocorticoids and androgens from the adrenal cortex. And finally, renin is a molecule that we use as part of the renin-angiotensin-aldosterone system. So excessive release of renin is going to lead to a downstream increase in aldosterone, which can ultimately cause disturbances in our volume and electrolyte status. Now, it's important to keep in mind about a specific scenario they like to test you about regarding renal cellular carcinomas and their involvement or their invasion in the renal vein. So I said that this can present with thrombosis and or varicocele due to invasion of the renal vein. So if you draw your attention to my little sketch over here, right, we have the renal cell carcinoma, the tumor, which is affecting the kidney right here. This is our venous vascular system, so this is the renal vein, and this is the gonadal vein right here. Now, if you pay attention to this renal cell carcinoma, right, what happens is this continues to grow. Well, as it continues to grow, we can actually get invasion into the renal vein itself that can create an obstruction to the gonadal vein. So typically blood is flowing up this way, correct? And then going back over here and back to the heart. However, if we have an obstruction because of tumor invasion into the area, this is going to create a blockage. So as blood tries to get back into the system, it's blocked by the cancer itself. What happens is we then get venous dilation, and venous dilation leads to a varicocele of that vein because we have an obstruction. Now we have a pressure system that is out of whack. Now, would you expect to see this if the tumor was on the right side of the body? The answer is no, right? Because on the left side, the gonadal vein drains into the renal vein, but on the right side, it drains directly into the IVC itself. And thus a tumor on the right side that causes an obstruction of the renal vein is not going to present with the varicocele or the dilated vasculature of the gonadal vein. Now, this invasion of the renal vein by the cancer, which we're seeing right here, helps describe our next point as well, which is that this tumor commonly metastasizes to the lungs and the bone. So if the tumor cells get in here, they're going to follow this way all the way up to the heart, right? What happens if it goes to the heart? Well, the next stop it's going to is going to be the lungs. And this is why it's a common place for this cancer to actually metastasize to. Now, it's also important to keep in mind that tumor cells have an affinity for the bones, and that's why we can also see it present there as well. Now, when we're looking at diagnostics here, we're going to start with some of our basic labs. One of the first ones we're going to get is going to be a urinalysis, which likely is going to show hematuria or red blood cells in the urine. But we can also get some imaging studies. So an abdominal CT is really going to be the best option here. So you can really see the size of the tumor, and it's helpful for staging the tumor. So we're looking at how big it is, whether or not it's metastasized to various lymph nodes. The CT is going to be the best imaging option for this. An ultrasound wouldn't quite give us enough information that we're looking for with this type of condition, although it is possible to see a large tumor on the ultrasound as well. Now, if we were to get a biopsy of a clear cell renal cell carcinoma, clear cell being the most common subtype of a renal cell carcinoma, you would likely see this on histopathology, which is commonly described as clear cells with high content of carbohydrates and lipids. And this is what gives the tumor its golden yellow color. So macroscopically, you're going to see a glob of golden yellow color. But under the microscope, if you draw your attention over here, you can see the difference between what's going on this side versus over here. You can see the cells are full of lipids and glycogen, giving them kind of their clear cell appearance, right? They're very white and appear to be spread out on the histopathology. And so this is an image they would want you to be familiar with on test day. They're also going to give you clinical clues, right? But they can give you the histopathology and expect you to make that connection between the types of cells you're seeing and the renal cell carcinoma. And finally, to wrap up this video, we're going to talk about management options. So ultimately, it's going to depend a little bit on what stage of cancer the patient has, right? Has it metastasized? Is it local? But one thing you can always consider is surgical intervention with a nephrectomy. But there are certain scenarios where this may not be the best treatment option, or there might be patient situations where they're not healthy enough to undergo a surgery, and thus we're looking more at medical management. One of the things that we can use is immunotherapy, specifically an interleukin-2 agonist, which is going to stimulate the growth of a variety of different cells, such as helper T cells, cytotoxic T cells, natural killer cells, with the idea being that these cells can then go and help destroy or attack the tumor itself. We can also consider some other things such as checkpoint inhibitors, and by inhibiting some of these checkpoints in the cell cycle, we can actually increase the growth of T cells. And finally, a high yield point I want you to know here, that this particular cancer has a poor response to radiation and chemotherapy. So if given this presentation of a patient with this cancer, and that's one of the answer choices, that would not be the best option here. Patients do not respond well to it. You need to use one of these medications, such as an interleukin-2 agonist or a checkpoint inhibitor, or if the patient is able to undergo surgery and actually have the tumor removed in the kidney itself, that is going to be a reasonable treatment option as well. So classic patient presentation for renal cell carcinoma is going to be something along the lines of a 60-year-old patient presents to the clinic. They are experiencing signs of blood in their urine or hematuria. They have a 30-pack year smoking history, as well as a blood pressure of 152/96. Which of the following pathologies is most likely? On physical exam, you notice that there's a palpable mass in the flank region, and you get a CT image that confirms there is indeed a tumor of the kidney itself. Well, we know the most common kidney tumor in adults is going to be the renal cell carcinoma, and so based on the information provided, that is most likely to be the answer. They can ask another question, or a two-part question where they ask you the pathology and then the diagnostic steps, and they could ask you about treatment options. They could say that it's a very large tumor that has not metastasized, and thus the best option will be to actually remove it and remove the kidney itself or do a nephrectomy. Keep in mind, they might try to trick you on this one and give you some options for treatment using radiation or chemotherapy, but we know that RCC is unique in that it does not respond very well to these treatments, so we would not pick that as our best option. So just to quickly summarize this video for you, renal cell carcinoma is the most common type of renal malignancy in adults that we need to know for step one. It often involves the PCT. We're going to remember that it can be sporadic or genetic. It's more commonly sporadic, but if it is genetic, we're typically thinking about the VHL gene, although it could be tuberous sclerosis as well. We're going to remember that VHL is located on chromosome 3, which is high yield for step one, I know. But our memory aid is that RCC, PCT both have 3 letters in it, and that's how we remember the chromosome 3 category. Now, presentation classically is flank pain, palpable mass, and hematuria, but we said only a small percentage of patients actually show up with all 3 of these, so these are not a diagnostic criterion that they have to have these to have this condition, but they are supplemental. The more they have, the more likely they are to have RCC. There are some other things that we need to know about, including the paraneoplastic syndromes. So a patient who presents with an RCC should probably get some additional lab work to work up and make sure they don't have significantly elevated levels of calcium, significantly elevated levels of red blood cells, because we know that these tumors can create those problems in a patient as well. So we need to check for them. When we think about diagnostics, we have our basic stuff, including urinalysis, our CT, and uniquely, our histopathology is going to show these glycogen-heavy, lipid-heavy cells that look kind of spaced out, giving it its clear cell appearance. And finally, for management options, we can consider surgical intervention or medical intervention, but it's important to know that this particular type of tumor does not respond well to radiation or chemotherapy.